There's nothing like a good cup of coffee in the morning, right? The sips of that aromatic, fragrant, magical stuff makes you wake up and tackle your day head on. And I'm really excited about today. What do they say? Good ideas start with conversation, but that great ideas start with conversation and coffee. So we're here to have our second coffee. And we're really here to talk about great ideas, innovation, topics, and more about specifically with our fascinating guest in the world of cardiology, medicine, healthcare, and beyond. So I'm Dr. Dipti Itchhaporia, President of the American College of Cardiology, and I'm thrilled to welcome you today to our virtual coffee table. We look forward to hearing questions from you today. At the end, we're going to have about a 30-minute discussion with our guests. We have two fantastic guests that I'm going to introduce you to. And then we're going to have a Q&A session, which you're really going to be a part of. So I really want you to be part of the conversation, as well as the conversation on Twitter. Use the hashtag ACC Coffee Table to connect with other attendees and share what you learn here today. I wanted to just go through a few little housekeeping things. A reminder that for virtual engagement, please remain muted when not speaking, and we encourage the use of WebEx chat feature. If you're viewing this live in the WebEx application, click the layout button in the upper right corner, and under stage view, select stack for optimal experience. So I'm going to go ahead and introduce my guest. Today, I'm joined by Drs. David Rhew and Sanjeev Bhavnani. Let me tell you about these two gentlemen. Dr. Rhew, David Rhew, is the Global Chief Medical Officer and the VP of Healthcare for Microsoft. He's the adjunct professor at Stanford University, and he got his Bachelor's of Science degree in Computer Science and Cellular Molecular Biology from University of Michigan, and then he went on to medical school at Northwestern, did his internal medicine residency at Cedars-Sinai, followed by a fellowship in health services there, and then followed that up with an infectious disease fellowship at UCLA. Started doing some research, and then I'll let him tell you later on how he actually got onto this path. But he holds 6 U.S. technology patents, particularly in the clinical decision science support and how that supports into health records. Anyway, he's served on the National Quality Forum and the Executive Committee for the Consensus Standards and Approval. He's chaired the Consumer Technology Association Health Technology Board and sits on the governing committee for NEST, that's the National Evaluation System for Health Technology Coordinating Center. And this is the medical advisory, the device advisory group for the FDA, CMS, and NIH. And so you can see, he's been recognized as one of the 50 most influential clinical executives by Modern Healthcare. He really is a thought leader in digital health technology, and we're very pleased to have Dr. Rhew with us. So welcome, Dr. Rhew.
Thank you, Dipti.
And then we have Sanjeev Bhavnani, who is one of us, as they say, a practicing cardiologist and a principal investigator of healthcare innovation and practice at Transformational Laboratory at Scripps Clinic. He's involved in the design of the next generation clinical trials and real world evidence programs with digital health devices, sensors, and wearable technologies, really to try to assess the impact of new innovations on healthcare outcomes, cost, and patient experience. And so to that end, he leads a team of clinicians, data scientists, entrepreneurs, biostatisticians, and engineers, and has developed how to integrate these methods. And we're going to talk a little bit about that. And Dr. Bhavnani is very well known at ACC because he's helped in our innovation program. He holds many leadership positions, and I'm really excited that he's with us. So welcome, Sanjeev Bhavnani.
Thank you. Bhavnani. Thank you. Thanks for the coffee.
So I'm really excited to talk to both of you because I think that one of the things that has been near and dear to my heart is digital transformation. I think, when you look at industries like entertainment or, banking, they've embraced digital transformation. And I think we have wanted to embrace it. We want to do it. And I think that COVID-19 really showed us that potentially we can. And I know that all of the tech giants are all in 100%. I want to know from an industry perspective, one, where do you think we are for digital transformation in healthcare? Are we further along than we recognize? Where do we think we need to go and what do we need to do to adopt it? So first, David, I'm going to ask you from your perspective, from an industry perspective, and then Sanjeev, what is it from your perspective that we need to do from a clinical perspective to even integrate it further? So David, I'll start with you.
So as my boss, Satya Nadella, has said a few times, we've seen 2 years of digital transformation in about 2 months. That's a remarkable transformation. And in healthcare, we've seen this manifest as acceleration in telehealth and video consults in remote patient monitoring. But we've also seen artificial intelligence being deployed in ways that we haven't envisioned. Use of chatbots. Chatbots could be used in so many different areas, but what we recognize is that they can be customized because ultimately the information that people are entering into the system to get those answers that they're looking for can allow them to be navigated to appropriate resources and services. So some really great examples of how this AI-based chatbot technology has been adopted during the pandemic was when people had a lot of questions, do I have COVID? And in fact, what typically happened was they would call the hospital or your doctor's office and the lines were busy. And then they'd go to the offices themselves or to the emergency departments, and we saw overload of the systems. In fact, many individuals who were not infected were basically sitting next to folks who were infected, and that was causing further spread. So to address some of these issues, what we realized is that we needed to adopt more broadly a technology that would give those answers very rapidly. And ultimately, within a matter of a day of implementing this, we saw dramatic reductions in call volumes and foot traffic into ERs and urgent care. And so what we realized is that this technology has tremendous potential, but it was the use case that really was the critical piece. And understanding those use cases now has given us a launching pad for other types of innovations and approaches, such as clinical trial enrollment. Now with these same type of concepts of understanding what the person needs when they need it, we can connect them to the appropriate clinical trials, or in some cases to plasma donation or to other areas. And this is just one of multiple different examples that we see today of how digital transformation has kind of, in many ways, provided us with the opportunity to address those major issues, but it is something that is providing immediate value to the individuals that use them.
Sanjeev, what do you think?
No, absolutely. And to continue, David, that 2 years and 2 months, it is certainly, we are at a new starting point. We're at a new starting point. And as we start questioning, well, where are we with telehealth and remote patient monitoring today, we can start designing again for tomorrow. And I think a lot of clinics now, whether within healthcare, but also importantly outside of healthcare, in a decentralized model of healthcare, our local pharmacies, right? But participate with us now in healthcare delivery, I think is also a very important catalyst, right, for access. So various clinics, various clinicians, and those involved in different facets of healthcare innovation can start asking these questions now. Well, we have it deployed, we have our catalyst, but we're going to be designing in a more individualized approach to the communities that we serve. So overall, it has certainly been it is here now a theme that existed a year and a half ago, but is still very prevalent today.
Oh, you're on mute, Dipti.
I forgot. I heard some background noise. I muted myself. But in the ACC innovation program has 3 components. We have virtual care, which telehealth, you could argue, is not all virtual care alone because we need other sort of augmented things for that. There's remote patient monitoring and there's AI. Tell me about what you think about those components as part of our innovation program. What are your thoughts? I mean, are those the right components, and how are we seeing some of those in the marketplace?
Well, I can perhaps start. First of all, those are the right components, but what we're also seeing is that in many ways, they're not distinct and separate from each other. There's interrelationships between how we use these tools. And in fact, what we oftentimes need are these systems of connection between the remote monitoring systems to trigger the virtual care prompts and the appointments and the scheduling, and the whole issue of getting people to the visit is a very important part of the journey. We think of virtual care as being the actual consultation or the discussion via video or perhaps even via phone, but the lead up to that is just as important, getting people set up along that way. And then when we think about what the information that we need to have presented within the context of the consultation, that's where we're talking about not just remote monitoring, but pulling in data from electronic health records, being able to show images, being able to share and provide consultation with your colleagues, perhaps even real time, where you might have multiple colleagues all doing consultations or discussion all at the same time. And so as we start thinking about how we incorporate collaboration into this and bringing in different third parties and allowing us to be able to transfer and secure information so that it's provided in a way that's helpful in the context of those conversations, we start realizing that AI can play a tremendous role. And in fact, AI has already been deployed in many scenarios to enable a more streamlined workflow. A great example is during the pandemic, we worked closely with one of our partners, Nuance, to develop a technology that has now been released that allows a clinician's conversation with a patient to be captured not just from voice to text, which is actually the easy part, but the contextual understanding of what was said is now organized into a progress note and integrated into the medical record. So we've removed all those extra steps that individuals have during the consultation to get that conversation into the EMR. And these are all the various ways that technology, those three components, can be intertwined to create a more seamless experience for the clinician and the patient.
So Sanjeev, talk to me about that. Where do you think we are? So telehealth is not enough. Where do you think we really are to put those components together from a real clinical perspective to be able to do that? Because really, we're kind of set in our workflows, right? And we saw that bump up in telehealth during COVID, up to 90%, but now we're down maybe like 40%. How do we sort of move that back up? And what do you think are some of the impediments?
Absolutely, right? So catalyst on one hand and the real world on the other, right? That 40% is in some geographies, and others it can be as low as 20. But that triad of telehealth as the access point, right, to get people, that just in time or right time healthcare access, the remote monitoring for the data, and the AI for the analysis. So in a model, it is something that is still very, very nascent, right? It is a lot of what we've learned over the years here at Scripps as we started designing trials very early on and then try to bring it into patient care. There's a very important fourth component, and that is the patient-physician interface, right? That whether virtual or in clinic, that clinical decision support. And we really have to ask the questions here now of, well, what are the expectations of our patients, their caregivers, and the providers, right, for an analysis of data that didn't exist before, right? And how are we making that actionable? Are we treating data or are we treating the patient? Right? And there's a very important distinction here, because we can get very attracted to treating data. Now, does that lead to an improved experience? Does that lead to improved outcomes? Right? That remains to be seen. But from that model, Dipti, as you've put it out from the ACC, it is certainly the right one. But it should be circular in that it iterates upon itself. The decisions go back to the patient, come back to the clinician. And that's where virtual care and clinics themselves will be able to design it in an individualized approach to a given patient, because, of course, no two patients are the same.
Right. I think what I'm really struck by, and one of the big pushes for doing a digital transformation and to really push for all of this, is this notion that maybe it may be the solution for some difficult issues that we've had. Quite frankly, we haven't been able to tackle health equity in a meaningful way, right? I mean, ACC's had that we've had that on our strategic plan, and really are starting to make strides. And I think that potentially digital transformation may be the solution. David, talk to me about that.
That's absolutely right. And it's funny when you come in with the approach of not leading with technology, which we oftentimes want to do because technology seems to have so many great opportunities to address issues, but look at the issues that people face every day, we realize that a lot of them are very complicated. And I'll give a real concrete example. As we've been looking to accelerate vaccination rates in underserved areas across the country, what we've realized is that the issue initially was, let's try to make sure that we've got these mass vaccination sites, and we stood up technology to enable those to be able to be available in conference halls and in other areas throughout the country. And then we shifted towards the smaller venues, which were clinics and some of these pop-up clinics that we were starting to see, as well as retail. But what we realized was that simply making it accessible in terms of making it convenient wasn't enough. We actually needed to start thinking about how we address the concerns that people have, the questions that people have. And that also needs to be done in a non-confrontational, unpressured way. So pulling in other stakeholders like local leaders, thought leaders, individuals who actually have connections with the people in the community that understand the concerns, that can address them, that can talk from the real world experience they're having, was critical to do this. And to bring individuals into that, they need to be empowered with the tools to make them knowledgeable about what the responses that can be provided. They also need the tools to help facilitate, if there's an interest, to then provide the vaccination then and there, not have them rely on the person to figure that system out. And so what we're realizing is that sometimes the systems that we design are designed more for our benefit because we expect people to come to our clinics, our facilities, our hospitals. But in many ways, we have to deliver care on their terms. And that means we need to understand what are those barriers, address those barriers. And technology is a great enabler. We can actually remove a lot of the barriers or make things easier by using technology. And that's one of the big lessons learned in how we've been approaching the vaccine equity issue, because what we find is that it's, in many cases, what we're doing is we're doing the same thing over and again and expecting a different result. And the reality is we have to start looking at how we work closely with communities and people that are working closely with the individuals, and find a way that we can empower them with the technology and the tools so that we work together.
Yeah, I mean, I think that's a really, really good point. What you said, that the digital tools are really just an enabler. It's not about the technology. And I also think that this idea of it being really the shift, from my perspective, if you go to digital health, is not about, if you think about healthcare is really, right now, healthcare is sick care, right? But this hopefully will be a focus on wellness care too, right? Truly prevention, and probably a lead towards value-based care. So Sanjeev, what are your thoughts?
I think, David, you've probably seen this the same way, right? Go where people are, right? Go where your learners and your communities are. And technology is an enabler. So when we take our technologies to such communities, we also take a means to upskill, right? To educate a workforce, right? Like community health workers, right? In refugee communities, right? Or in underserved communities, in homeless clinics, right? That the technology is the vector. The skill set is what will be delivered, right? And I think, David, you've seen that in your experiences with vaccination, as we have too, with our vaccine, our hypertension programs that go into communities which have largely been underserved, and really start learning about barriers to access, but also just barriers to good information, right? And so this empowers a community, right, that is trusted, right, where we as a healthcare, are somewhat non-accessible. Maybe there is distrust, but there is a partnership that can occur there, and the vaccine effort, of course, is that catalyst, and a very, very important examples that we've learned from. How do we use that now, right, for chronic diseases? How do we use it for wellness, right? Keep communities healthy, right, that have otherwise been marginalized, that live in food deserts, right? And so that's where a lot of what we do together, right, can move that discussion forward.
So what do you think that our listeners, what do they need to know if they want to be in on being part of digital transformation? What is it that they need to do? What do they need to do? What do they need to learn?
If I can start here, Dave?
Yeah.
Please.
Just do it, right? Get started, right? When we started doing this, we're very lucky, almost 10 years ago, but it really started with let's one patient population and one device, right? And that's really where where teams come together, right? Whether in clinics with nurses, with MAs, or with your healthcare administrators, IT, IS, it's really getting to learn this language of technology transfer, technology development, the engineering aspects of it, and then keep it very broad. You know, one of our first examples that's very sobering was we had 20 different blood pressure devices on a table, and we had a patient advisory board that came in. We were looking for elderly hypertension programs, of course. This was 2013. And the feedback that patients and their caregivers gave to the devices went back to the device companies and redesigned it, because we take for granted how things are connected, how they're charged, how they're connected to your smartphone. Is there adequate Wi-Fi? Where is that data going? All these questions come up. But had we not asked it from the patient's perspective and in an inclusive model, we went down the road of let's deploy it, and it didn't work. So I think that's where, when people want to get involved, see what the gaps are, right, in your workflows and access for your patients, and how can a technology then be incorporated within that problem, right? Versus looking at as this technology is designed, now let's create the service delivery around it, right? And I think that's where clinicians, innovators, clinical trialists can get started.
Yeah, and to add on to that point, getting involved can take the form of so many different ways of ultimately having an individual start to use the technology would be one. But then there's another extreme of, now that they've adopted and are learning, that can they help develop and refine and make this better? And that's where we want to move the needle, where we have individuals actively participating in studies to evaluate how the technologies and other tools can be used more efficiently and effectively. What we find is that a lot of the technology and tools that we build are built on limited data sets. For instance, artificial intelligence would be a great example. As we've learned to really understand how this works in diverse populations, we need to enroll new patients. We need to find ways that we can deploy this in communities that are underserved. We need to start thinking about how we modify the algorithms accordingly. We need to associate those with the outcomes that we care about. And that's clinical work, that's research, that's activity that ultimately can be done by a broader group of individuals that are activated and engaged in this process. And that's what we need more of.
Yeah.
A couple other thoughts that I had, and before we open it up for our audience to ask questions. But one is, you know, and somebody in the chat wrote this, that almost always we label technology as progress, right? And often technology is a burden. So how do we overcome this? Because I've always thought that potentially this could be a way to overcome clinician, you know, the burnout, and maybe help with clinician wellness. So how can it not be a burden? You know, how can it really help with clinician wellness? David, maybe it's a big, broad question.
I think with all advancements, there's always 2 steps forward, 1 step back. When you think about even starting with the electronic health record, we all know that there was great value in terms of digitizing this. There's tremendous upside, but in large part, simply digitizing it is not enough. In fact, it created extra burden, which added complexity and time to people's days. And that was a major step backward. But now what we're starting to do is address those through natural language processing, artificial intelligence, ways to streamline care, ways to bring some of these workflows outside of the traditional physician interactions, so that perhaps they can be handled upstream or by other individuals. There's so many ways that we can redesign the clinical workflows, and that's what we're now starting to do. And I'll see probably in the next, or we should expect to see in the next few years, greater advancements in terms of clinicians being able to better utilize these technologies. But the first round was just simply getting people to get exposed to this whole concept of moving from paper to digital. And now that we're at that point, we need to start focusing on how do we improve that experience. And the technology will definitely help. It's just a question of, can we advance this in a way that allows us to be able to provide value along the way? And that value needs to be in the form of making it easier for clinicians, time efficient, allows them to be able to have a better experience with patients, and allowing patients to be also generate the benefits from all this technology that's being deployed.
Yeah, and I'm going to jump in and say that I think the true definition of digital transformation is something that improves your life and not necessarily. And so I think we confuse electronic health record as digital transformation. And I don't think that's digital transformation, really. I mean, I agree that we've gone, but I think that true digital transformation, the way that I envision it, the way that I think, Sanjeev, you talk about it, the way that I think, David, you talk about it, is something that's going to ultimately make our lives better and the patients' lives better. Agreed, Sanjeev?
Absolutely.
Agreed, right? And
Yeah.
with that, there's great resources within the ACC. The Innovation Member Work Group has grown exponentially, as of course Dipti and many know. And speak to your peers, right? Everybody's trying to figure it out, right? And one workflow that works for someone may not be the ideal workflow for somebody else. But we can certainly learn from each other. We can share our experiences over these past 1.5 years, and what is it that we are expecting in that digital transformation for our for enhancing, right, our workflow, and that will emerge through this community of people asking these questions.
Right. Can we afford all this? Can we afford this digital transformation? And are we paying for it?
In many ways, we're already paying for it. We have invested so much into the technologies, and what we're realizing is we're not getting as much out of what we put into it, largely because they've been applied in areas that perhaps aren't creating as much value. And so, if we think about taking some of that waste, that the cost, that investment of things that we're spending time on, and shifting it towards things that create value, that allow us to have better experiences, we can become far more efficient, and that's ultimately the goal of what we're trying to do. We need to use technology efficiently, prudently, and the benefit from both clinical as well as an economic is there. It's just we have to start realizing what things are creating value and what things are making things worse.
Sanjeev, you have thoughts about the cost issues?
Absolutely, we have to be critical, right? And to David's balance, right, on looking at it from both sides. We must keep costs, as much as we keep access in the central focus of digital transformation. We have to be cognizant of cost. So wellness on one hand is preventing disease, right? Keeping people healthy. On the other, getting people the right care at the right time, right? And we largely know that cost has a factor there when that is very, very long, right? Whether in time or disease burden in communities or advancement of disease states. So I think we do have to be very critical, right? Of the technologies are moving faster than our model of delivery, right? It's I wonder, David, it's not about catching up, right? Healthcare to technology. It's about marrying the two in the right model for a given population, right? Is that perhaps that's where we learn about cost efficiency and cost containment.
Yeah, I mean, I think, technology has moved ahead. There's all this technology, David, that you've mentioned, but the delivery systems really haven't changed. I mean, telehealth is the most recent one where we've changed a little bit. But I agree that we need to marry that with what's happening in the digital world in terms of all of this stuff. Because a lot of times these tools are being made, but I'm not sure how much they're really married with what we need. So this idea of being together is a good thing. There's so many questions I can ask. Certainly, I know that the audience is itching to ask us a bunch of questions. I wanted to just touch on one thing before we pivot to the questions, which is, and somebody mentioned this in the question, which is the issue of how there's so much interest in this field, right? I mean, we have a huge member section where people are. David, I think they want to hear, how did you pivot from what you did to that? And are there pathways for somebody listening that's interested in having a career in what you're doing and being an influencer in the digital world?
I'll share a little bit of my story. I'm not sure how generalizable it is. It obviously has some time-dependent nuances that ultimately may not be present right now. But back when I was in medical school and in residency, I had no vision of using technology as part of a career. In fact, I don't even think anyone really did. It was largely, there was no EHRs back then. There was no, I think the only technology we had was a PowerPoint and some word processing to write papers. So this was not a huge amount. MRIs and CTs were used, of course, but the whole concept of digital transformation was foreign. And when I started out, I started asking questions that we were just talking about here. How do we make care more efficient, more equitable? How do we allow us to improve the experience for patients? And by asking those questions, what I realized was that in many ways, technology was the only way to enable this. In fact, I did a clinical study when I was a fellow, and it was about improving vaccination rates in the VA. And what I did during that time was I enabled nurse protocols to be activated within the different clinics and demonstrated that we could improve vaccination rates dramatically. Well, sure enough, after my study was over, I checked a year later and vaccination rates had reverted back to normal or back to baseline. And that's because without a system, without an electronic system or some kind of a mechanism to keep things going, you can't have behavior adapt consistently. So you need to have these systems in place. And that's what really got me interested in looking at how technology could be used on an everyday basis by individuals across the entire care continuum. And now what we're at is where we've seen the technology advancements and now the adoption of digital technologies in the clinical workflows. And there's tremendous opportunities even beyond what we have today. The big opportunities lie in looking at how we can expand care outside of the four walls of our systems of hospitals and clinics, addressing issues that relate to community care, looking at ways that we can address the barriers to care that are oftentimes referred to as social determinants. And what we want to now start realizing is how do we improve those experiences that we have in the process of building the digital roadmap, but have also made it very bumpy for clinicians along the way. How do we streamline that out? So with every one of these, we've now got new technologies that are being developed and deployed. Artificial intelligence is a great example, and we need to figure out ways to incorporate them. My journey has been one where I'd say I started down one path. I realized that in large part I needed to continue to understand how technology could be deployed into that. I was provided an opportunity to do some of this work working in an electronic health records company, Cerner. I worked there for a few years and then continued to build decision supports that were integrated into other EHRs, moved on to mobile technologies where I was chief medical officer at Samsung, and then ultimately now starting looking more at data and interoperability. And I think as we start thinking about that journey, it's a very similar journey of where healthcare has been. Healthcare has moved from the concept of EHRs to mobile to now looking at how data and AI can be applied. And I would say that it's not too late. That would be one of the key messages for clinicians. Clinicians can start learning about those opportunities to apply these technologies into their clinical workflow, into their research settings, become experts within certain areas. And within that context, they can then establish an opportunity to be able to work in collaboration with those that develop the technologies so that they can improve how we deliver them.
Sanjeev, do you have any thoughts before we go to the question and answer?
Oh, just to David, to your last point, your journey is so impressive, and just it's a lot easier now, right, for clinicians to get involved. Things are more available, they're more supported. Clinics, industry, healthcare organizations want their clinicians, right, to start asking questions. So, in contrast to David and even myself, when started, there was very little. I can count on one hand. There were 5 devices that we had access to at Qualcomm when who supported me, but we started asking these questions, right, from a clinical standpoint. So for the clinicians who are interested now, it is probably far more exciting, right, than it was a number of years ago. So again, just to get involved.
Yeah, so let me go to, I mean, like I said, there's so many more questions that I can ask both of you, but let me go to some of the questions that we've had. So one, Sanjeev, this was for you, and there was said there's been a lot of progress in clinical trials in hypertension with home blood pressure monitoring and data technology. Or I guess that was the question. Has there been progress in the clinical trials with hypertension with home blood pressure monitoring and data technology?
Yes, they're a very good question. I think the person who's asking, this is a large base of the pyramid, right? People with hypertension. And so there has been a lot of clinical trial designs that we can learn from that have made progress. One is just with remote monitoring. right? So on one hand, there have been lots of trials that have looked at just remote monitoring individuals. What happens when you give blood pressure devices to people? And blood pressure comes down in the short term, right? By about 3 to 5 millimeters of mercury. It sustains when it's down, when trials have shown us that it's a co-intervention between remote monitoring, pharmacists, nurses, physicians that are providing ongoing education, medication titration, right? So clinical trial data can show us that we can improve blood pressure through participatory models. This is the third component here that came out of the UK and then out of Michigan, right? And that is pharmacist-run remote monitoring hypertension programs, right? Completely decentralized from our clinics. We're not there for delivery as yet here, but very important from what trials can show us on efficacy, safety, right? And how we can do a task shifting, if you will, right? Or again, a shared participation between clinicians, patients, and their community. And then the fourth one that is emerging now is directly at the community level, community health worker driven hypertension models, right? Teach people, it may not be medication titration, but teach people about health and wellness, diet, exercise, etc., about hypertension. So an excellent question that encompasses a lot of the last number of years of where are we with hypertension devices and care models, and now up to us and Dipti to the ACC, right? For how do we, start doing that as part of clinical care?
Well, and I think that's what the barbershop study showed, right? I mean, in the barbershops, with having the pharmacist and titrating, having that comfort level, being in the community and all of that. So I think that you really make those points. David, the next question maybe is something more you can address, which is somebody said, we talk about using technology for marginalized group, but many do not have smartphones or internet. How do we talk about technology when many marginalized groups don't even have this technology? This is that digital divide question, right? So maybe what are your thoughts about that?
So this is something that at Microsoft we have recognized and have tried to act on and serve as a leader within the community and the world. To enable people to have digital access, we have to start thinking about ways that we can work in collaboration with the providers of these technologies. And in large part, it has to not just be accessible, but it has to be affordable. And to do that, we have to start recognizing that to create systems where people have greater access to affordable broadband, it starts even at the policy level, where we have federal funding allocated to services. And we are now starting to see that, where it is now being incorporated into legislation, where that is a part of what we expect as infrastructure. Infrastructure used to be about roads. It's now got to be about roads and digital infrastructure. And if we think about this as a critical need that is applied across the entire country and the globe, we will realize that we can do a lot more. And it doesn't have to wait until legislation's passed. We've actually implemented programs working in collaboration at the local level to institute broadband access, affordable broadband access to individuals. And this was part of our initiative called Airband, which was started about 4 years ago. To date, we've serviced about 14 million individuals globally to provide them with access to affordable broadband, over 1.4 million in the US. What we realize is that this is an ongoing journey, because once you've given and provided access to affordable broadband, the next step is digital skilling and education and training, and allowing us to be able to then take advantage of what we now have. And that's where a lot of the jobs are going towards as well. People who have a skill and an ability to be able to work within a digital environment. And that then leads to addressing some of the bigger and broader issues that we see. So this is a multi-step process. We are at the stage one of where we're at. We need to get them to understand how to use it, and then make the experience better and easier. For some individuals, we'll talk about seniors, those with disabilities, and other aspects. It's just it may seem obvious and intuitive for us to be able to do a video consult, but that's not necessarily the case for a large number of folks. And so we have to use our existing services and tools to be able to address those major barriers.
Right. And I agree. And I think there are programs where they give patients' smartphones and even tablets when they're participating in programs. But I agree with you. It's about public policy. It's about advocacy. ACC's advocated for the telehealth and certainly for broadband access. I think we're going to need some more at a policy level, we're going to need to do some work. Another question, it says, I see a lot of opportunity for innovation and recruitment for cardiology fellowship, but also for faculty recruitment. But for most part, we rely on older systems like word of mouth, web search, email. I wonder if the speakers have other ideas for improving recruitment processes for applicants and programs through digital transformation.
So, great question. And definitely, training and upskilling the next generation of cardiologists and healthcare workforce and practitioners is the ultimate goal, right, of digital transformation. And so it takes time, right, to build in an innovation curriculum because it has to be very responsible, right? It is about education first, merged with clinical care. So what has helped us here and myself personally is being trained in informatics. We came from, regular traditional, fellowships. I didn't know what informatics was until presented to me from an informatician. But there's a language there that is really important to learn, right? And that is all part of this digital journey. And so digital health, artificial intelligence can learn a lot from the field of informatics. Now, if that's within fellowships, right, within residency programs, medical schools, well, now, our students and our trainees can start asking different questions. It will require faculty, that are, versed in these fields as well. So that's where, the faculty recruitment, I think this individual had asked this question. It's a work in progress, but certainly, for health systems and training programs to start embedding digital design thinking, right, are the basics of artificial intelligence. Artificial intelligence is very nice. It sounds good, but it is intricate. It is complicated. Requires quite a bit of education just in basic statistics, right? So before one starts tackling machine learning with neural networks and deep learning, there has to be a very good foundation here of clinical and analytical statistics, right? And so that all has its foundation within training programs. So get out there, talk to peers who are doing it.
So here's a question from, it says, could you give some examples of technologies that are being utilized in healthcare right now? Some examples of these technologies and how they're being utilized. So maybe Sanjeev and David, you can both give one example each. And I really want to try to get some of our audience members to ask a question. So there's somebody that I see that I recognize on there that I'm going to call on next to ask their question.
Well, I'll provide one example. What we've seen is that we follow a model today that I would say needs to change in education and training, the see one, do one, teach one model. That model, as we're all well aware, requires that we see a lot of different types of these procedures. And that means as a medical student or a resident, you're running around the hospital trying to find that particular procedure to either see and or do. And that is something then that requires, as you start doing the procedure, a mentor or someone to oversee or look over. So if you're going to have to do a more complicated procedure, it requires what will be ultimately the rate limiting step of a senior individual to oversee that particular procedure. And this occurs at all levels of training. We talk about medical students and residents, but even as you start getting into more advanced surgeries and procedures, you need that mentorship and you need that guidance from more senior experienced proceduralists. And to do that, what we realize is that to get to the top of that pyramid, it's very difficult and it takes a long time. And the ability for us to have experts in certain areas more broadly spread. So if we talk about access to care of high quality care, that's impossible if we follow the current model. Now, the example I'm going to share is an example that we recently saw in Mount Sinai, where we're working with one of the clinicians. He was advising a surgeon in Uganda on a procedure where the Ugandan surgeon had never done this tumor excision. And in the process of using a mixed reality headset which allowed the surgeon in Uganda to be able to see visually as the surgeon in Mount Sinai was tracing on his computer in New York, exactly, it was overlaid on top of the patient where to make the incisions. And now what we're starting to realize is with technology, we can remove those barriers of distance, not just through a video consult or for voice, but actually physically overlay that on top of the reality of what we see in front of us. And that real-time decision support, that ability for us to be able to guide people in either mechanisms that are virtual or perhaps through some semi-automated mechanisms, is going to transform the way that we think of how care needs to be delivered and education and training can be delivered. This gives us the opportunity to start thinking about global training centers that could allow us to be able to have that outreach across the world and allow us to be able to start thinking about skilling even the folks that are not necessarily within the traditional healthcare world on procedures and activities that need to be done that are critical for the urgent needs that they have in their areas. And this is now all enabled through technology. And one of the exciting things about this is it's affordable, extremely affordable, because one of the things we're looking at is there might be something like a headset that would be used that might be the higher price point by one individual, but across the globe, everyone could be using their own computer or other types of tablet and devices. So you don't necessarily need to start thinking about how this scales in terms of the price points. But what it does is it enables us to scale in terms of the skill set and an ability for us to be able to expand that globally.
So I see Leon Parker had several questions in the chat box. I don't know, Leon, do you feel comfortable coming on and camera and asking those questions? Because you had several of them, but maybe you could ask one of those questions.
Hello, I'm actually in a doctor's office right now getting my labs drawn, so I couldn't talk, but I do have a lot because I built a lot of programs nationally, and actually one of the first cardiac and invasive and diagnostic imaging programs that was for evidence-based guidelines for authorization. And then now I've actually built out a robust chronic care management PCM and RPM program.
Great.
Congrats.
And so that's why my questions, I don't know which one you were into, but
Well, you ask whichever one question that you want to ask.
okay, so I think one of the biggest issues is the fee for schedule model and the volume model versus over quality, and you can only get 15 minutes with your patient, right? So would any of the entities like Microsoft or ACC be willing to engage a program that offers an extension of the provider's office in an RPM, CCM, PCM program, to where you're really engaging the patient between the visits and you're really understanding the dynamic of what's going on? And then a lot of the devices have cellular. There's not a lot of smart devices needed. You can acclimate nimbly to somebody who doesn't have smart access or internet access. You have to, like, if they didn't have internet or ability, like with technology, that they could actually, they're engaged by an MA or a nurse in their area, and they're managed, and you see really good outcomes. But I don't see anybody really talking about that, making themselves an extension. And I know I've built the program and it's going really well. We've had really good outcomes, especially with CHF and hypertension, but I don't hear a lot of partnerships going on. So I don't know if you guys, I guess that's my main question.
So I'll maybe start. One of the things that we realized is that to make this process, what you described, a movement from fee-for-service to value-based care, a reality that's sustainable, we need to get the support from the major payers, including both private and public. To do that, what we have to do is we have to demonstrate immediate value from both an ability for us to reduce costs on a larger scale basis and put that in the context of existing programs, and or launch new programs that are supported through federally funded grants and or other mechanisms. That's actual activity that we have in place today. Talking in our discussions with major payers and other organizations, they are interested in those programs to understand how can remote monitoring and extended care types of visits virtually be applied into specific models so that we can provide either whether it's bundled payments or perhaps a larger shared savings model. And those are things that we would want to continue to explore with collaboration with the payer partner, because ultimately without that payer partner component to I guess the team, we can't create a model that beyond simply a pilot. And this is where we are actively working with organizations to build those models and see whether or not we can apply them. I'd say one area that is ripe would be in the Medicare Advantage space, where you've got an existing model of care that allows us to be able to support that. And if we can find ways to apply this into the MA model, that would be a perfect example, but there probably are others as well.
Oh yeah,
Right.
yes, Dr. Rhew, actually all the payers are pretty much paying for RPM and CCM. And it's just, I think the logistics aspect of it, you have to make yourself an extension of the provider's office because they don't have time to manage it, right? They're already over inundated. So that's where our model's different.
And Leon, you're using terms that maybe some of the audience members may not
Oh,
know
I'm
what
sorry.
some of those are, please. So if you could just clarify.
Remote patient monitoring is RPM, CCM is chronic care management, and PCM is principal care management.
Right.
And so with cardiology, if they don't have any other, if they only have one chronic illness, you would use PCM care, which is billable through Medicare and most major payers. And then CCM is if they have two chronic diseases, and you can manage them that way. And you can bill up to 60 to 90 minutes a month and just care coordination, social, like social worker type thing. So, excuse me.
Great. I'm going to go on to, there's so many other people that have sort of logged in. Neil Stone, you had a comment and a question about maybe sort of, maybe Neil, if you don't mind making your comment and maybe asking a question if you had one. I have several others that want to ask questions too, so. Or maybe he was on earlier and not now. Okay, there's Avnish Gupta.
Here, I'm back.
Okay, great.
Yeah, I put a computer on my desk in 1985 and started my electronic medical record. I designed a Excel workbook, and because of hyperlinks and whatever, created a fantastic record that allowed me to give patients terrific handouts, wrote prescriptions, kept everything in one place. Of course, there was no communication with other doctors then, so it was perfectly safe. And then when Epic came in, I was happy to go over to Epic because of all that it provided. But patients still said, you know, I loved your little handouts and the way you use electronic record better. Because one of the problems is, and it was mentioned before, that individual doctors have their own ways of doing things. And unfortunately, we don't learn enough from each other. Sanjeev, you made that point. I thought that was a fabulous point. And and yet here we have human mannequins that teach our residents how to do procedures so they can hit a jugular vein and they can put in a paracentesis and do a swan. But maybe one of the things we should be doing is showing doctors who see primary care, who see heart failure, who see EP, who see risk factor management, better ways to take care of their patients. We use flow sheets for acute care that now we've got on a medical record, but we don't have really good models. I mean, some of us have our own models, but we don't have good models for how we do flow sheets for chronic care. So we have these bloated visits. If you ever see some of the electronic records of patients that I see, they're bloated. They're all these forms that somebody has filled out. I can't get to the core of what is the new information or what's the relevant information. It's very little. But if you can't see it, you can't act on it. And so the patient tends to just do the same stereotype things. And maybe we need to have a task force that looks at a better way of teaching all of us how to really use what we have. We're talking about getting more advanced when I don't think we're even coming close to using the potential for the EMR. I'll be quiet now, but those are my
Well,
comments.
and I think this is about more than EMR, right? I think it's about these new processes, care processes. And I will tell you that ACC Innovation Group is working on that and sort of rolling that on. Sanjeev, maybe you can just briefly speak to that.
Thank you, Dr. Stone. Yeah, looking at where the gaps are and where our challenges exist, and they actually probably are magnified now more than ever, right? Is how do we maybe decentralize that process and to try to find the solutions? One thing that we've touched upon here is that specialty primary care collaboration around virtual care, right? Like the data that we have, who is reviewing it, who's acting on it, and who's communicating to the other person on this particular patient. So we've learned, just basic hypertension. Primary care clinics are inundated with it. How can cardiology clinics partner, to Leanne's point, right, on that flow sheet model, that following higher risk patients with blood pressure, right, remotely? offer our suggestions, right, to risk reduction, and then almost hand off that patient back to primary care. Is that a sort of collaboration that we can look towards in making our data more efficient? And then Dipti, the ACC innovation, working with other organizations, like Evidation Health and Heartbeat Health and others who are looking at building, this type of technology-enabled collaboration, but from that perspective first. So not that it's a technology that we're using, it's a facilitated collaboration. So, so Dr. Stone, to your point, maybe this is the opportunities for us to do some good design thinking, right?
Right.
And the ACC
Right.
does.
So Mohammed Mansour had a question, and I think this is an important one. So Mohammed, I'll read the question, but maybe you could just go online so we can see you. It just says, I want to ask about cultural revolution, how to face over resistance from clinicians who think that digital health has come to replace them. And they've always been afraid, they're afraid because of that from technology. I mean, we hear these fears, right? But I think, David, you pointed this out, that it's not really about the technology. So tell me about your thoughts when clinicians have this fear.
Yeah, I think largely it's because of the fact that we haven't.
In einem Podcast on remote patient monitoring.
Oh, I'm sorry, I didn't quite catch. Well, okay, I'll proceed. One of the things that we oftentimes find is that we roll out the technology without a proper introduction. And that introduction needs to be in the context of that technology is an enabler. It is not there to try to remove the critical tasks that clinicians need to do every day. Now, that said, there's a lot of things that can be automated and made more consistent that allows us to be able to become much more efficient, and where the clinician can spend more time on the higher level complexity issues that we oftentimes look at. So yes, there will be some transfer of responsibilities to technology as we start moving down that digital roadmap. But in the end, that will allow the clinicians to spend more time doing the things that are of high value, which are the things such as interacting with the patient, understanding and being empathetic to their concerns, to be able to take that information from all these different disparate sources and analyze that. And when the computer comes back with a recommendation, to be able to say yes, but, or and be able to add the elements and make those decisions that are most appropriate. As I mentioned before, technology is constantly evolving. Even the artificial intelligence systems that we oftentimes see, many times we learn about what is needed from the folks that are actually actively working in the field. And that is where there's a collaboration that needs to occur as technology is developed. We need to better communicate upfront what the purpose is, explain how we can make things easier, better, and then work with organizations as they start trying to adjust their own workloads to incorporate the technology.
Yeah, and I think education keeps coming up. There's a lot of questions about how can we get educated about AI and all the different technologies. We do have a digital transformation committee. There's the innovation section. So there's lots of tools out there, so that we can help that. And I think that, we need to not only educate the clinicians, but also the patients. So I think there's a lot more work to do. This was a great discussion. There's many more questions, but I want to be mindful of everybody's time. So I want to say I really want to thank my guests, Drs. David Rhew and Dr. Sanjeev Bhavnani, for joining us from a virtual ACC coffee table today. You'll be able to find this recording of these sessions at ACC YouTube page and learn what we're going to be chatting about next on acc.org and the ACC coffee table. And honestly, this has been just wonderful. And I will say, I'm going to raise my mug for coffee. And Sanjeev, and may your coffee be strong, and may your day be full. May we help, and may we heal, and may we advance heart care worldwide together. Thank you for the opportunity to be with you today. And thank you all for stopping by. Thank you, Sanjeev. Thank you, David.
Thank you, Dipti.
Thank you.